program we started last week. Had some trouble with video, and we're back to try again today. Hopefully we'll get a good recording. And PowerPoints have been sent, I believe, to all the registrants. We have posted the PowerPoints from this presentation on the Maryland Nursing Workforce Center website and on the NSP2 websites. So we're going to get started. As you can see from the beginning slide, put your questions in the chat and I will moderate them and bring them up to Dr. Billings at the appropriate time. So we want to keep the flow. Be sure to mute your audio to reduce background noise and feedback. You must complete your CE evaluation form after the workshop to receive credit, and you'll be given instructions on how to register. Those instructions were with registration. And CE is provided free, courtesy of NSP2 grant funding. And we hope you enjoy the presentation today. We need to move to the next slide. There we go. Today's topic, I couldn't do it. Choosing and using a clinical judgment framework across the curriculum. Dr. Diane Billings is our presenter. She's a Chancellor's Professor Emeritus from Indiana University School of Nursing and is known to a lot of you from the CNE preparation workshops she has been conducting here in the state of Maryland. So without further ado, and to get us moving, I'm going to invite Diane to start her presentation. Thank you.
Well, thank you, Becky. And I want to start with a shout out to Sonia Smith and Anjali and you, Becky, for helping be such fabulous tech support. So we're off and running here today. So just to start, some information that everybody needs to have from the CE office. This is an educational event and there's no relevant financial relationship with any ineligible companies to disclose. None of the planners or speakers have financial relationships to disclose. And with any of the companies whose primary business is producing, marketing, selling, or distributing healthcare products used by patients. First, really, we're thankful to the University of Maryland School of Nursing Office of Continuing Education because they're accredited and with distinction as a provider of nursing continuing professional development by the ANCC Commission on Accreditation. So we're grateful to their support, and you're going to be able to get 1.5 contact hours for attending this activity. But as Becky noted, be sure to complete the evaluation that will be sent to you in your email and, complete it fully. And then within 2 to 4 weeks, you'll receive your contact hours. So I think we're all set with that. And, just as we always do, we have learning outcomes here. So here they are. We're going to talk about the advantages and disadvantages of several clinical judgment frameworks. And I'm hoping that you're going to choose one that, works for you across your curriculum. I'm thinking several of you maybe have already made some decisions about this. And, we talked about at the summit, this was really the first step for getting started. You see the green flag there. So if you haven't started, hopefully this session will give you some ideas to at least make some decisions about how you're going to use a framework and integrate it throughout your curriculum. And then we're going to do a little case scenario, patient situation where we're going to use that a framework and, kind of see how that would work if you're, how you're going to integrate it into the curriculum and how you're going to use it with your students. And then we should talk a little bit about the barriers and facilitators to implementing a framework, because it's going to take some time and thought and planning. And I know you guys have all also, have somebody as the point person for all of this, but, we need to kind of think ahead about what's going to happen and how we can make it a smooth process. So that's what we hope for today. And I'm also hoping that you've downloaded the slides, because we're going to do a little clinical case study, as I mentioned, And I think you'll find it easier to do if you have that information in front of you. Okay, so let's get started. And again, this slide, I probably put it in every time I talk about clinical judgment, because we need to know what we're talking about. And the key word that I like in this definition here is it's observed outcome of critical thinking and decision making. And you can observe this outcome as you're working through the clinical judgment framework that you're using. You can see it with your students in their clinical behaviors. You can see it in their writing if you're doing concept maps or anything like that that you're working with in the classroom. You can see it when they do simulations. So we're looking here to understand what the students' judgment, what they're coming up with their clinical judgments. And, they have to have some knowledge. That's part of this. And, really the bottom line here is that we want the students to be able to make good clinical judgments, safe ones for their patients. And for us as faculty, the good news is we can teach it, students can learn it, and we can see it as they're going along. And actually that word tested, because we're going to need to help the students understand how to take the test questions that are on the National Council State Board of Nursing new NextGen test plan. Okay, so let's talk about some of the frameworks. And, there's really a good reason to use one of these 3 or 4 that are out there that you may have access to or want to use, because it really helps the students learn to make these effective clinical judgments. It's a structure, that is going to help the student, but it's also going to help you as a faculty member so that you can organize, how you're going to teach the class, how you're going to thread this through your curriculum and so on. So it seems like it's a really powerful tool to use, and it really helps then looking at the context for making clinical judgments, consistent way for the students to think about how to do nursing care. And the more the students use this model, the sooner it's going to be automatic for them, and it's going to give them some confidence that they can make good clinical judgments. We have evidence that it improves when you're using a framework. And, as we mentioned too, it's really going to help guide how you're going to choose or integrate clinical judgment into your current teaching and learning and testing strategies. Okay, so here is the slide that talks about the pros and cons of 3 popular models. And when we did the survey there in Maryland, we found out that quite a few of you are using the Tanner's clinical judgment model with Lassiter's clinical assessment rubric. But let's go back up here to the top, because there's 2 others that maybe some of you are using or would be useful to you. So we'll start with the one that the National Council is using. They call it their clinical judgment measurement model. They changed that after they first came out, because they're wanting to emphasize the fact that they're using this framework to write their test questions. So right there, that's an advantage, because the students and you all have thought about using this model and how it's going to show up with test questions. So it focuses on judgment, and it's a very deliberate process. Actually, there's 6 steps, which is more than some of the other models have. And the other thing that's, for me, is an advantage is it really emphasizes the context, the environmental and individual factors, and we're going to talk about those a little bit. But on the downside, it makes some changes need to happen in your curriculum, and you'll have to weigh if you want to use this framework or others that you maybe are more familiar with. And probably everybody's familiar with the nursing process. This is a 5-step model, and the pluses are probably everybody and your current students are familiar with this. And because there was dialogue between the National Council and some leaders in nursing education, the National Council did change or aligned the nursing process with their model. So they had some kind of a sense that there was some alignment and some similarity. So that gives it a case for thinking about nursing process, that's what your curriculum is using. And the one thing though to think about if you're using the nursing process is that it really was originally designed as kind of a care planning model, and it doesn't emphasize the judgment steps so much, but it's not difficult to put the judgment steps in after each step of the nursing process to ask the questions about what decisions did you make, or what judgments did you make at each of these steps. So there's two of them that seem doable. And then the third one is the Tanner's clinical judgment model, which many of you are using, and actually the national study that the researchers themselves discussed at our summit, it also will work. So it has 4 steps, but I think they kind of fit together there. And then the real plus for that is that there is a clinical assessment rubric. And I think that's probably what attracts a lot of faculty, is that it really helps to evaluate the student's ability to do clinical reasoning and judgment. So, and there's some others too that I've heard faculty talk about. And if that's something that's tightly embedded in your curriculum and you can make it fit, I think there's nothing wrong with that either. So there you have some options. And I'm going to talk just a little bit more here about the National Council's model. And here you can see that the key steps here are layers 2 and 3, the steps. And you guys have seen this model too, I'm sure, many times. And you see down there, layer 3, the environmental factors, and we're going to talk about those, the individual factors too. But then you'll see there at the bottom how the nursing process is aligned here. And you've got the color codes to note that. So I just bring that to your attention again. And we'll kind of walk ourselves through this process a little bit here, layer 3 and 4, so that you understand that, and then we'll kind of bring this all in alignment again. So you see there at the top those 6 steps, but what I want to emphasize on this slide is that there's other things that provide a context, and they're not identified as environmental factors and individual factors. And so some of the factors that need to be considered, particularly in that first step when the students are recognizing patient cues, what is the environment? What have they observed about the patient? This model brings in lots of other data points, what's on the medical record, physician's orders and lab values and things like that, and how complex whatever the situation is, if it's a code versus somebody, patient teaching situation where everybody's in fairly decent health. So and cultural considerations as well. This is something we are emphasizing in the curriculum for sure. So those things need to be factored in no matter what model you're using. That's kind of my thought, because that's part of how the measurement model is going to work. And then there's also the factors that relate to the nurse. And for our students, we're thinking, well, how much knowledge do they have, and how well can they do their skills, and have they had some experience, or are they beginning students and have very little? And there's something particular about the student, and actually we can say the nurse as well. This is because this is not just for students. This is a model that we want to have translated back over into nursing practice when they graduate, and for all the nurses to do too, because those medical errors that drive this, they are not all made by students. So we're really trying to improve better clinical judgment for nurses in general. Okay, so I'm going to tell you a little story here that hit home for me, the importance of this a model. And this was a friend of mine that I was visiting. I was more or less trying to serve as her patient advocate. She had fallen and hit her forehead and had a subdural hematoma. She was in the hospital for evaluation, and at this point she's down on a step down unit and still being monitored. But and this student nurse came in and asked if she could do a physical assessment on her, and my friend said yes. And so the student started doing the physical, the routine physical assessment. And then when she got to the neuroscience, she asked my friend to do the hand grips, and one side was weaker than the other. And then she asked her to raise her right her hand, right hand, and her right leg, and the patient couldn't do that. So I knew something was wrong, probably even maybe a little bit more than what the student understood the implications for. And so I ran out and got the nurse, and the nurse ordered or had the healthcare provider order a CAT scan, CT scan, head CT scan. So the transporter comes to take my friend to have the scan. I brought the transport cart, and the transporter asked my friend to stand up and get on the cart. And the student stepped out of the way so the patient could get up on the cart. And, I took a deep breath. And what the student had not done was to take a look at the environment. She was so focused on getting that health assessment done, she didn't see that my friend had red slippers, which at this agency means that the patient's a fall risk. She had a safety belt around her. This is, just the pic. This is not my friend, it's a picture, but my friend had, that safety belt around her chest, and she was sitting on an alarm pad. And the focus here was, for the student, she was just focusing on getting the health assessment done. And I think this maybe have been her first clinical ever, I'm not sure, but she was a junior student, and it was her first week in clinical again. And so this, to me, points out if the student doesn't gather all of the information, particularly the environmental and individual, in this case, the individual factors was the fact that the student was, she was a student, a junior student, but she missed all the other cues that were part of this story. And had I not been there and the patient, my friend had stood up, she was a fall risk. So the student missed coming up with putting the cues together in a way that came up with the diagnosis that this patient was a fall risk. So, I, of course, said, well, I don't think she can stand up. That's not, she's going to might fall. So we got some more help, and we got her back in bed, and then we raised the bed up, and we used a 4-person lift to get her over on the cart. So to me, you can just see that behavior, the clinical judgment came up with the wrong diagnosis. So this is, to me, is really the importance of that, looking at the context in which care is being given. So let's go forward here. So I'm going to walk through all these different steps here. And what I've done for you is I'm using the words that are in all 3 commonly used models, the National Council's nursing process and Tanner's. So I think they all kind of work the activities that we want the tasks that we want the students to do at each of these steps probably translates in some fairly recognizable way. But again, it's what happens after each of these tasks. So you see there the list of things that's going to happen when the student recognizes the cues, and then you have to say to yourself, see that behavior from the student somehow in writing or in actions or in verbal conversation, that they have recognized the cues that are appropriate. And then the next step, of course, is to analyze these. And that's what didn't happen with the student who's taking care of my friend. So in analyzing the cues, the student and the nurse puts things together, clusters the data, recognizes patterns, sees what's going on, and kind of connects the dots. And then also maybe says to themselves, I don't have enough information. I need one more thing. I need to, check a lab value here before I do anything else. So, this is putting this all together here, analyzing the cues. Next step is to prioritize the hypothesis. So, in using the nursing process, we, call that making the diagnosis. In Tanner's model, we're interpreting all of this. So, this nurse students coming up with, putting this together, coming up with some kind of a conclusion, looking at, what's really going to be most important, the urgency of it and all. And then, probably thinking through, what's, most important. So the next step after that happens is to generate solutions. And in the nursing process, we know that is planning. And in Tanner's model, it's called responding. So here, we want the student to be looking at the desired outcomes and some possible interventions and things that they're planning and things that they shouldn't do and things that they absolutely should be. And again, they're probably thinking about the priority. And then also a lot of nursing care's team, for the student, and I needed the team of other people to come help us, first of all, call for the CT scan, and secondly, to get the patient transported safely. So other people might be involved in this particular step. But then you can see by talking to the student or by asking them to write it out, what things did they think about here as they were planning? What solutions did they generate? Okay, then the next step is to take action. And in the nursing process, we call this implementation. And then Tanner's model, we could relate this to responding. So this is where the student's going to do something. Maybe it's a skill, maybe it's give a med, talk to the patients, do patient teaching, write things down, and all this time observing ethical and legal behavior. All those things that we want the student to think about before they do anything with the patient, before they take action. Okay, and then they take the action. Did I miss the slide here? Take action, and we did that. Okay, and then the last step is to evaluate it. And nursing process, we evaluate, and Tanner calls this reflecting. So we're looking at we're wanting the student to see the impact of what they did. Look at what they desired outcomes and what happened. So they need to go back and kind of think through what happened to the patient and so on. So this this is a very linear step-by-step process, but at any point, if something happens and goes wrong, the student doesn't come up with a clinical judgment that's not appropriate or not going to be safe for the patient, things can go drastically wrong. So, that's what we're wanting the students to be able to, smooth out and get going, rather quickly. So let's now kind of think about how we would integrate all this into the curriculum. What is it going to take to get the students to this point where they can be more or less automatically thinking about how to make clinical judgments? And now this falls back on us and our nursing education planning and our teaching learning process. So I think it's easiest, this is me, to use one of these frameworks. You can see how they kind of align, and if for some reason it's not going to be possible that everybody gets on board, weigh that, but the consistency of a framework is what's going to help the students get there. And I think this can be used in almost all courses. Research courses have their own process. I'm not sure there's any, I can't think of any other course in the curriculum where this using a clinical decision-making framework wouldn't work. So the more the consistency and the more courses that the students see this in, the easier it is going to be for them to get to automaticity, which we want them to, this needs to just click for them. So then another thought about thinking here, how to use this, is we want to know that we're focusing on the clinical judgment skills here. And yes, we're teaching content, and the students have to, learn skills and knowledge and application level of kinds of things. But we're really wanting also to see that they are, doing the clinical judgment process. And I think the other thing that I've noticed when I've talked to faculty about doing this is that everybody more or less needs to be on board. And when at the summit, we talked about some of your faculty are part-time, some of them are only teaching clinical courses. And so we want to make sure that everybody understands what the framework is and how to use it. And this in some ways is a curriculum process kind of thing too, because if there's people are using a framework in a variety of different ways, that's probably not going to be helpful to the student. And if you haven't done a systems check on how you use any of these frameworks, you might be surprised to find out the variety of ways that it's being implemented. So, this would be a good time to just touch base with everybody and see how it's being used, and that if there is some consistency, across all of the faculty, and figure out maybe you have new faculty you've never discussed this. The other thing is, talking about clinical judgment, and when back at the summit, we pointed out this is something that's a program outcome for all of you. You may call it something different, and it's for sure if you're in the process of revising your curriculum for changes that are the new essentials document, you're trying to make some changes for that. This is the time that you can think about this in terms of your curriculum, and if you spend some time thinking this through, you've got your accreditation report all written for you. So try not to think of this as something that's way out of the scope of what you're doing every day. So make sure that everybody understands, all the faculty understands and knows how to use it. So then we need to be sure that the students understand how to use this framework. And you want to, I would think this is something that you're going to introduce at the very first nursing course that they have. And you want to explain the process to them, but at this point they don't have a lot of context or background or information of nursing information to use, but they all would have something that they can relate to. Like, I'm sure most of your students have had pain or had a fever, or anything else that would be something that they could relate to and work through the process. And then I've heard faculty or the other people who talk about using these models. You can also back up and use just kind of a practical model, and choosing what to wear on any given day. You go through a judgment process there. Maybe that's something the students can relate to, but you want them to understand, something that they can use it here at the very beginning. And the other thing that I think is probably is essential here is that this is a process. Clinical judgment is a process, and it has 4, 5, or 6 steps. And you want the student to be able to go through all of those steps each time they're thinking about a patient. And sometimes we think, oh, beginning students don't have enough information to be able to do this all the way through. We'll just teach them how to do assessment, or we'll just teach them a skill and see how they can fit that into the process. But the more the students can see all the information that they're learning fits into a clinical judgment model, the easier it's going to be for them to make it. So I'm a big advocate of trying to be sure that even first-year students have an opportunity to do the whole process, and that that we're really trying to get the students to do this in all of their courses from beginning to end. And at the end, they're going to get much better, of course, because they have more knowledge, and you can be more. There's the complexity of what the students can do in each of those steps is going to really expand. And then you want to be able to prompt the student so that you can see the behavior, that visible behavior. So it needs to be, you can have it in verbal forms, talk to the student. What are you thinking? How did you come up with that decision? All the way through, or you can use written ways. And then of course, the ultimate is that they're going to take a test, and more or less like the one they're going to see on the licensing exam. And that too will test whether they understand, how to make the clinical judgments. Okay, and then just a few more things that come to my mind about how to go about doing this. And you all, when we get into chat, you can add some further thoughts if you would like. So consistent terminologies, and that's part of if the model, and so use that. And if you're not using the National Council's model, I would say work those key words into your discussion, because you can say assessment, you can say recognize cues and notice and the students will understand, but the test questions on the licensing exam are going to use the words from the National Council model, and those will be, the stems in the question. So if you're not using that model, kind of get your terminology so the students understand the steps. And then, going down forward here, after you have made some decisions about how you're going to, what framework you're going to use and how you're going to implement it, then you can think about the teaching and evaluation strategies that you're going to use throughout your curriculum. And we're going to have lots more workshops on the details of, how to teach and how to assess and evaluate. So that will come. But for now, I would say start with what you have. Don't get fussed up about, changing everything. Figure out how you can integrate it into your course assignments and your teaching and so on. So that's that. So right now, I think would be a good time for me to just stop and ask if you have any questions. What are your thoughts at this point? And post them in the chat. Dr. Weissman's going to moderate and let me know what's on your mind at this point. So does this make any sense? Is there anything that I can clarify or add?
Okay, I'm looking at the chat box right now. We don't have anything, and is Sonia here? I was wondering if she could. Oh, here's someone who wants to know if we have the rubric for the Tanner's model.
Where you can get it is it's published, and I'm not sure if the resources here at the very end have that, but you could do a search, and she's written the framework and the model, and I think recently in Journal of Nursing Education, I think Lisa Gonzalez and Kathy Lassiter and one other person wrote up about making clinical judgments, and there's a nice the diagram of the model and the rubric, I should say. Yeah, so that's where I'll direct you for now.
And we will be having some workshops later, probably in this spring, where we will be talking about the rubrics for the Tanner's module using Lassiter. We may even have Kathy Lassiter make a presentation on it. So we do have some of those resources coming up probably in the spring, because we're starting to get towards the holidays when we get into November and December, and we thought we'd put a hiatus on and come back in January, February for workshops.
Okay. So Becky, I'm going to assume that everything's crystal clear if we don't have any more questions.
Okay, so, here's another question I have.
Okay.
It says, first, good afternoon and thank you for the session. I have seen the nursing process steps with assessment, analysis instead of diagnosis, planning, implementation, evaluation. Is that the more acceptable terms now?
Yeah, I think that would work. Absolutely. Yeah.
And I think it was at the bottom of that National Council. I think those were the terms they had put in there to kind of marry those two models together.
Yes, I think that's exactly so. Thanks for bringing that to our attention, because that analysis of the assessment for nursing process is really what's important. And I know some faculty, across the nation are still helping the students learn nursing diagnosis, but do know on the licensing exam, nursing diagnosis is not, they aren't using the classic nursing diagnosis that many of us grew up on. So they're just using more generic terms for the, a health problem or so on.
Okay, that seems to be it at this time. If there are questions along the way, I will bring them in.
Okay.
There was a question about the recording. Yes, once we're finished with this one today, we will have the recording posted on the Maryland Nursing Workforce Center and on the NSP2 websites, and we'll let you know when they're ready. Okay. All right, go ahead, Diane.
Okay, thank you, Becky. So now it's your turn. We're going to go through a little scenario here, and I'm hoping that you have access to the being able to do some active learning here about the framework to make a clinical judgment. So we're going to have a patient here who has incisional pain following surgery. So I'm going to, give you some data here that we'll use throughout the case study. But what and you'll need to use it, but what I want to say is we're going to hover over this situation and focus on the clinical judgments. It's very easy to get mired in the case study. And so do the case study as we go along, and I'm going to prompt you through it, but not to worry. So I like to make sure that when I write a case study, and Kathy Martin's going to walk you through the steps of writing a case study. That's the next session up here, and that will be posted up next. So she's going to, go through a framework and a model of how to do that. But what I kind of like for my own self-check is, first of all, we to start with a learning outcome or learning objective. And here this is planning a care for an adult who's experiencing post-op pain. And, if your curriculum is concept-based or competency, right, whatever that is, for me, I just wanted to make sure I was focusing on the pain part of this. And then I like to make sure that I understand what I'm expecting the student to know here. And there's kind of the list of, what they would do. And then some of this particular scenario requires some skills. They need to know how to use a pain assessment scale, and they have to know about vital signs and how to interpret them. And then they also need to know about a pulse oximeter and how to use an incentive spirometer and what that's used for. And then it's kind of a thought too to think about where does this go in the curriculum. Probably you're writing this for your students in your course, but for me, I was thinking this could be somebody who's in a beginning fundamentals course. You may or may, this would be dependent on how your fundamentals course works. But I do think this is something that a beginning student probably could manage. That's what I was intending here. So let's take a look at this. And here's some information about the patient. He's 40 years old, male, and he had his appendix removed. And it's now 10:45, and here's what the nurse's notes tells us. So take a minute and look at that. And that's some information. And as you're looking at it, you're, doing some interpreting. And I'm going to move to the next slide so you know what you're going to do with this information. And also you need to know that the patient can be up ad lib and he can have some morphine, and his IV is running at 60 drops a minute, and he can have an incentive spirometer every 4 hours. So take all that information. I'm going to pause again for a minute. And what cues did you recognize and what are significant? So I'll wait just a minute until you have a chance to do this. Remember, we're hovering. We're waiting to watch the clinical judgment process here. So don't get too carried away with worrying about the data.
Okay, people are starting to put in. One person put restlessness.
Okay.
Complained of pain, 9/10.
Okay.
9 out of 10.
Yeah.
Respirations were decreased.
Okay.
Respiratory rate was 24.
Elevated.
Another one, respirations increased. The wife is at the bedside.
Okay.
O2 sat 91%.
Okay.
Just out of post-op. Someone wants to know if we can put the scenario back up.
Yeah.
They don't have the PowerPoint with them.
Oh, okay, sure.
And another one says 45 minutes since returning to the unit.
Okay. Good job so far. All righty. So I'm going to, if we don't.
Let's see, some more coming in. The client's wife is anxious.
Yes.
The pulse ox on the right arm is below 95. Up ad lib is concerning. Absent vowel sounds would be expected at this stage. IV less than the order. And that's it so far. IV running out, but no urine output.
Okay, some addition. Well, we don't have that information about the urine output, I don't think, but interesting to note.
Let's see.
What
it says has not voided, but not concerned yet.
Oh,
Not
I'm
voided.
sorry. Let's say that has not voided. You're right.
Right,
Okay.
right. Yeah.
Okay. So,
Okay.
all righty. So I'm gonna. You made a great list, everybody, and I'm going to say what I'm thinking was our significant cues, because this is what the student really needs to pull together. And you noticed, the restlessness and the pain and increased respirations and the pulse ox, O2 level is low. The wife is anxious and she's, requesting the pain medicine too. And you might have pulled out too the smoking history, because that may make a difference in terms of setting some, understanding why he needs, to get out of bed and do some things like that. So take deep breaths and use his incentive spirometer. And here are some things that I would say are not expected or not significant, things that would be normal and maybe even irrelevant in this situation. And I think you noticed all of that. The fact that the absent vowel sounds, you mentioned that, and it's true, but whether that's expected. So when we're trying to figure out what's most significant, and this is, when you are working through something like this with a student, this is one way you can handle that, is you can first of all say, we're in a teaching learning mode here. We're just trying to figure out, what kind of the best clinical judgments to make for this patient. So then you can say, it's true that he doesn't have the vowel sounds, and that's, helpful information, but is it going to be significant? Because it really isn't. And I guess you want to ask the students to say, how do you think about this? What concerns you about the fact that the patient has absent vowel sounds? And then maybe if the student says, well, I expected that I would hear the vowel sounds. And then, right then and there that you can do some teaching and give some feedback and say, we don't expect the vowel sounds to come back right away. And it's probably going to be another day or so, but what can we do to help help the vowel sounds to come back? Okay, and the fact that he had not voided, that's probably expected too, because it was just, really not too long ago. But it's also something that you can talk to the student about, because if some of you thought that was, a significant situation, and he's oriented, we didn't need to talk about that, and the IV should be infusing as prescribed. So this is kind of how to think about a clinical situation and to work with the student. But then we're going to go to the next step here. And what do these mean? So this is the analyze step of the nursing process, or analysis of the cues, and what cues are concerning and how do the data link together. So think about that a little bit and see what you can come up with of some significant interpretation of the cues or the analysis of the data that you have so far.
Nothing yet.
I will give him a few minutes and
It takes a little bit longer.
yeah, it does. And if I'll go back.
Okay, well, it's starting to come in.
Okay, good. We can go ahead.
Here's one that says, not breathing deeply. Is that related to pain? Restless with low oxygen saturation, hypoxia. Let's see. I'm trying to get down to bottom of my thing here.
Okay.
Poor perfusion.
Okay. Oh, those
Okay,
are good words to use for analyzing the cues. Yeah.
Poor oxygenation.
Yep. And, we can also, we have a lot of data about the poor oxygenation, and we probably could have even had some more, well, first of all, we have his respirations, and we have his pulse ox there for sure.
Inadequate pain management.
Yes. We knew that from his restlessness, from his wife, and from pain scale.
It doesn't sound like he was verbal, so he didn't. Was he verbal? I got to go back to the case study.
We didn't say that, but he reported.
He said 9 out of 10. Yeah.
Yeah, so we'll say that he was verbal.
Okay.
Okay. So I'm going to just move us ahead, Becky, here, and come up with
Sure.
what seemed like how to put this all together, and I think everybody got that. So this is the next step, and then if the student comes up with something else, that's helps you then know. And again, you're going to say, we're in teaching learning mode. I'm just what made you think about something else that's not on this list. And sometimes when the student talks to you about their thoughts, maybe their thoughts picked up something that you didn't, and that would work too. But I think here it's pretty clear that these are the cues and the things that we how you came up with those issues. Okay, and then the hypothesis, where to start, what should be the nurse do first. So we can this is one action step, one hypothesis to come up first with. So this should be quick. And if you analysis or nursing diagnosis or whatever you want to call this. So quick post on that.
Let's see. I got secure airway, acute pain, maintain airway, pain management first, give pain meds.
Okay. So this is I'm going to show here what I thought was the priority hypothesis, and I think it's the pain medicine. But for some of you that said, was talking about the airway, so then we're going to say to the student again, we're going to clarify that we're just in a teaching mode here. This is not judgment. We're not grading you. What made you think that? What information did you put together that came up with the fact that the airway needed to be secure? And what would be the pros and cons of dealing with the pain first before you dealt with the airway? So then, the student will give you some information, and then you can use that as feedback. And for me here, coming up with giving him the pain medicine, then he's going to be able to get up, and then he's going to be able to breathe better, and he's going to be able to use an incentive spirometer and dealing with the pain first. So that, again, helping the student know that, priorities and how they come about. Okay, so action steps. And what do we want to have happen? And I can probably just go ahead and talk about this because it should be pretty intuitive here. We'll just skip ahead a little bit. So this is what we want to have happen. We want to decrease the incisional pain, and we're going to give the pain medicine. We're going to get the patient up and help him ambulate, but we're going to do it after he's had the pain medicine. So that's a kind of a teaching point for this beginning student. And then we want to make sure that the oxygenation level improve, and we're probably in addition to ambulating and helping him take deep breaths, we're going to get him to use the incentive spirometer. Okay, so I don't think I'll have a disagreement on that. So then the next thing is what action should the nurse take? And I'm going to, say that. I think the pain medicine. But now let's go to the next part of this story. And now it's 11:30, and here's the nurse's notes that you should take note of. Okay, and what you're wanting the student to do here is to look at changes. And they can see what the original was up there at 10:45, and now it's 11:30. So there's a reference point for the students to go back and look at what's different now based on their action that they've taken. Okay, so what the question here at the end on the evaluation is, did what the nurse do help? And how do we know that? What data do we have that shows that the interventions or actions, steps are working, implementation stage? And what follow-up data? Maybe sometimes we can ask that question too. So here I'll entertain information in the chat. What do you think happened, and what outcomes did we achieve?
Let's see, we improved their respirations and the pain level. The pain is decreased, the patient is more comfortable. Pain decreased from 9 to 4. The patient ambulated a little and voided. It was better on, I'm keeping up here, better on pain, but 400 mil voiding is quite high with IV still at only 60, and patient likely not yet drinking. Okay. And oxygenation improved. I'll just make a comment about the 400 ml voiding. We don't know how much fluid they got in the OR and in the PACU, so we don't, unless we have that record.
Yes, and thank you, Becky, for pointing that out. And then for the student who says that, that's exactly what you want to, prompt them to find out why they thought that and what other things did they need to know to come up with that decision. Okay. So it sounds like we got just about everything. Is there anything else there that, Becky, we should think about? And I'll buzz here to the next slide. So same things that you guys said, the pain decreased, the oxygen sat and improved, and there we have the case. So see how, this can work, and the information that you can come up with, and how to interact with the students when you see this. And you can, as you more or less we did here, this is in some ways written down, and you can have students fill out a care plan or chart or something like this that prompts them through, and then you can give them the feedback based on what they tell you from the written work too. Okay, so now that we've understand what the process is and how to go through it, the clinical judgment process, and all steps to be used, because we want to work it all the way through to the end. And I don't know if you would agree, but to me, this was a very simple case scenario, because we could make it much more complicated, for a junior student who knew more about post-op care, and we could have an infection, we could, have things that are much more complicated. But it would seem to me that the, a basic student would know how to interpret vital signs and, manage pain. So now I want to ask you, what barriers and facilitators do you need to anticipate as you're going through this process to get this integrated into your curriculum? So in the chat, let's first of all talk about some things that are might happen as you're trying to get all the faculty on board, and then from there we'll talk about facilitators. But basically, some of you maybe have already been through this, and if you've had barriers, it would be helpful to others to know what they were, and we can talk a little bit about how to overcome them. So, post in the chat, and Becky will, report it out to us.
Nothing yet.
Okay. Give everybody a minute to think about this.
Here's one, all faculty buying in.
Yes, and that probably is one of the biggest things. And, the first step is to find out what faculty are doing about clinical judgment, and how many of them are there. Do you have enough of a consensus of one way to go about this? That would be, kind of a solution to that. But first of all, you're going to have to find out. And I think I mentioned once before, I was working with a student in a leadership faculty and in a leadership project, and it took her a whole semester to find out what was going on. They were going to use nursing process and how that was used in their curriculum. So yeah, getting everybody to buy in and maybe change a little bit. Okay, so that's for sure going to be a barrier.
So another was similar, very senior faculty who have challenges with adapting to change. It was working just fine. Why do we need to think? Why do we change? And then lack of knowledge and understanding of CJ versus nursing process versus critical thinking.
Okay.
Departing from what we've always done and learning new framework while teaching at the same time. That is difficult. Sometimes we get so obsessed with providing every detail that could ever be needed that we paralyze ourselves. That's a good.
Yes. So sounds like, the barrier here, another one is the change process that people may have to make. And, dealing with change is always difficult, but sometimes explaining what the change is, how much the change is, and if the people are already using nursing process, the change would not have to be a big leap, and finding that out. How many of your faculty are using nursing process as opposed to other two possibilities or any other possibilities may help you decide which way to go. So make the change the least amount of it as possible. Another strategy is to do kind of like we've done today, to work it through, show how they're probably doing something similar, how to work with the students. But I like this notion of hovering over the facts of the scenario, because you're also looking for what the students are thinking, and actually critical thinking is a part of that definition. So they're thinking, but they're making decisions and judgments at each step. So that's what we want to hover and watch and give feedback to the student. Okay.
We have, I'm sorry, we have another comment. This is from someone who says, we use Lassiter-Tanner, and identifying the behaviors for achieving each level can be difficult. As mentioned, faculty in foundations or fundamentals don't think they can use all the steps because the students don't know disease processes. Integrating the clinical judgment model is easier in a clinical course, but doesn't seem as easy for the theory courses.
Okay, so I saw two issues there. One is going from the simple to complex throughout the curriculum. And it is for sure that the students that, who have more information under their belt will be able to process more complex kinds of things. But the beginning students, as I thought this example, I intended it to be something very simple, that the students, once they learn vital signs, you can make it even simpler, because what you want them to know how to do is not just memorize what they are, but to interpret them in a clinical situation. So you can give a clinical situation of a patient who has just an elevated temperature, but they have to look at the vital signs. Even if it's as simple as giving ibuprofen or acetaminophen or whatever, to bring down the temperature. And then, 2 hours, an hour later, take it again. That's a very simple, go through the process. So granted, beginning students don't have as much information as they're going to have later, but you're teaching a process. And it's as simple as deciding what to wear the day. There's steps, and they can do that, and they can have some very basic information. So that's one issue. The next issue that I heard was, how to integrate this in a didactic course. Well, in some ways, we just had an example of how to do that, because this is a very didactic, straightforward PowerPoint presentation. You could do this in a class. You could have, with your PowerPoints, you could have a simple, a scenario that's appropriate for the information that you're teaching the student. And this is a good way to solidify all that information and help them put it together. So you could teach it more or less like I did for you here. And then because we had a pretty good dialogue, I thought, just using the chat functions. If you're online, you can make that work pretty well. But in the classroom, you can be much more fluid and dynamic. So there you're giving, it's a teaching, and Kathy Martin, is going to talk too about making this environment safe and comfortable so that we can have these conversations and the students trust us, that we're just helping them learn. And so I think that's one way to do it in the classroom. Another way is to show a little video clip and have the students do something with that. If you use simulations in your classroom, and we're going to have more information on that later, that's another way of getting the context and having the students make judgments as they go along the way. So if you want to do a classroom assessment technique and have the students see a clinical situation and then ask them to write a little reflection on the steps that were taken, that would be another way. In the classroom, you're not typically in a grading situation. Clinical, it's a little bit easier, but you also have the post-conference where you can run through something like this so that every student sees the steps. So thank you for those good questions. And you're thinking really well about how to work this through. Okay, Becky,
a couple of people said there were some other things you could do in foundations. You could look at infections, you could look at oxygenation. And then one person responded and said, I will be playing this recording for my faculty fundamentals members to hear you explain it better than I seem to be able to.
Well, I'll admit it takes a little more time and more thought to get the context in it and follow the process, but for sure it can be done. And that's, we have to start there because we're building, and even throughout the fundamentals course, you'll at the end they'll have more information and you can make the cases more complex.
That seems to be it, Diane, and I just would like to reinforce that it is a process, and just like we start to learn, quote, nursing process and fundamentals, you use it all through. So it's you learn the steps and you learn the beginning and then work it through. So no more comments.
Okay, good. Well, then we can go to the next thing here, which is about the facilitator. So I would love to hear if for any of you that have worked through some of these barriers, and these are they're the ones that are out there, they're going to be common, you're going to deal with them, but people who have dealt with them, or those of you that could just think of a way to make this work. And I think we kind of just talked there a minute ago about facilitators, is to think through some examples of how you can work the process into your teaching.
Not seeing anything yet. I think people are thinking.
Yeah. And barriers and facilitators, those are words from a change process model, freezing and unfreezing. And so some of this is a change process, and we don't want to just be stopped by the barriers. We need to think through what's going to make this work. And all of you guys know your colleagues and your faculty, and where the bumps in the road are going to be, and what you can do to help them move ahead. So so if we have some ideas for facilitators.
Well, we don't have anything yet, but I think the comment about using the recordings to help faculty see how it could be done as an exemplar looked good. Okay, so here's some more now. It takes a
Okay.
while to type in.
Yes, it does.
Seeing it in action, actually doing it, and here's one: provide 15 minutes spot in service for all faculty of how to incorporate this. So, small chunks. This one says, you've given me an idea of how to present unfolding case studies during class,
Right.
maybe as a brown bag lunch, probably for faculty as a brown bag lunch. I made that interpretation. If I was wrong, let me know. Okay.
He's not inviting us. For,
Yeah. Can we have brown bag? The answer is yes. That's what they were thinking for fellow faculty members. Yeah. Okay, that's good.
okay.
Some good
Yeah.
ideas.
Yeah, and I think part of it's knowing your faculty and, knowing how to help them make some changes. And I know you guys have a lot other changes going on if you're switching from, a concept-based curriculum to a competency-based curriculum. There's lots going on, but while you're in the unfreezing mode, now's a chance to, embed this as well as you're going along. Okay.
Okay, here's another comment. Said, take some basic scenario story and let faculty work through different possible problems they might be able to use this on. Pain, as we did, maybe in a higher level, we might do shortness of breath, and we could use that has not voided information.
Yeah.
And here's
Yeah, go ahead. Thank you.
and another one's, time is an issue, and faculty are very busy to do this whole thing all they are to do. So maybe that goes back to the chunking, giving
Yes.
the brown bag
Yeah,
lunch,
right.
having a 15-minute, kind of chunk it instead of one whole day and then go forth and do it kind of thing.
Great. And Becky, I'll put in a plug for the rest of the series. These are all going to be chunks. So this is more or less the first step. And when Kathy talks to you about how to get the case studies going, that's going to help you a lot too, to figure out where to get them from and how to write them. And all this was just, the example of how the process works and how to, teach it a little bit. So they're going to have, and then you're going to have some teaching strategies and assessment and evaluation strategies. So we're planning chunks.
Okay, that seems to be it now, Diane.
Okay, well, good. And I'm going to just kind of see if we can wrap this up here. These are kind of my thoughts and what I would want to kind of think of take-home messages from this. So it's about using, helping the students learn through some kind of a consistent framework. And, there's options there that you can choose, but getting one and having most of your faculty commit to it is probably where you want to be here soon, so you can, start integrating it into your curriculum and your teaching and evaluation. And then we just did these barriers and facilitators, and you can think about this at your school, what's going to, where the bumps are going to be, and then how normally when you need to help people change, what works there. And I like the notion of those chunks of information, how to help people understand where we're going. That's going to be helpful too. And I'm optimizing faculty time and resources. We can't spend all day on this, obviously. So you want to make sure that you're getting the biggest bang for your buck and keeping this, somewhat simple. Okay, and then kind of highlighting again about the need for this process needing to start early with the students. It's very simple, and it may change a little bit how you do some of your teaching there in the beginning, but you're wanting the students to think of how they're connecting all the dots of what they're learning, in all the courses in that first semester. And, the full process, sometimes faculty just like to focus. This is me years ago. Remember we were trying to teach student nursing diagnosis. Well, that was the column that we spent most time on with the students, and we never really got the whole nursing process taught. That's my recollection of what happened there. So the same thing, we have to be careful that we're not emphasizing any one of these things, but it has to go through the whole thing. The other thing we saw, the real problem that can happen if the students don't get the cues right at the beginning and understand what how to analyze what they mean in that fall risk. was just as clear as it could be to me sitting there watching my friend, but the student was immersed in thinking about how to get the skill done that she was assigned to. So then we've talked too about the increasing complexity. So when the students have more knowledge, you can build these cases. And actually you can take that pain case, you could simplify it even more and then build on it, because when they come to med surg, when they come to palliative care, all kinds of other things, you can add many more contextual factors into that. But the whole point is that we want safe care. And I don't want to go visit another friend of mine and find out that she fell because the nurse didn't understand she was a fall risk. Okay, so now we're kind of wrapping up here. So any final questions, thoughts, whatever? Becky, if you can, one more time, we're going to see if what else is on anybody's mind, and I'm happy to answer whatever.
Nothing yet, but I think people are thinking it takes a little
Okay.
while for it to come through the system.
Yes, it does. Yes,
I'll put a plug in. You put a plug in for Kathy Martin's next workshop, which is on October the 20th. I believe it starts at 3:30 and goes to 5 o'clock. Flyers were sent out to all through the deans and directors meeting and through NSP2 today. You can also go on the Maryland Nursing Workforce Center website. Just Google Maryland Nursing Workforce Center if you don't know the website. And you will find under events the flyer with the registration information. Okay, so let's see. People are saying thank you. I need to get my, okay. They said the link to the recording will come to our inbox. I believe so. I will make sure they do. Is there a shift in focus from prioritizing interventions with NextGen, I guess? And I think that's the question. Is there a shift in focus from prioritizing interventions with the NextGen? That was the question.
Yeah, as opposed to prioritizing the nursing diagnosis or the hypothesis. I think probably they go hand in hand. I don't think it's a shift in, I think you prioritize the hypothesis and then the interventions or implementation or taking action. You can come up with several steps for that, but there's one that they're going to, if the question asks, what should the nurse do first? That is a one thing only, one answer only, because that's first. But if you're thinking about what are the possible actions that a nurse could take, or what are the possible implementation or interventions that could be there, then you would want to see some things that are possible. And then usually in the test question, they'll have some things that really aren't such a good idea either. So I don't know if that helps, but yeah, if it asks for priority, that or what should happen first, that's what to do for sure. Okay, anything?
Okay, people are saying it's very helpful, that the more you hear it, the more it makes sense and it'll be less daunting. People
Good.
are looking forward to the recording. And then there was a question, I think, referring back to this, for example, what interventions would the nurse do first? I think relates to the prioritizing. And they're starting to come in a lot all of a sudden. And this is very helpful. Thank you. The exercise did help. Thank you for the great presentation, very helpful. Those will not go away, I believe strongly, because the NextGen is only a small percent of the exam. I think it's the other kinds of questions that will be asked.
And Becky, I'll just put in a plug too. You have to think about making your test questions, if you're in the process of revising them, getting them bumped up, using context, using lots of pieces of data. And maybe it's not the full process, but it's a step in it that you're asking the questions for. And that will help, because if the students miss too many of the traditional questions and then also miss all the NextGen, that's not good. So if we're going to shore the students up, we're going to have to shore them up on the traditional questions as well as on the NextGen. Just a thought.
Okay, and then more thank you. It's very helpful. Appreciate it. Some questions about the recordings. We will not be able to send the recording directly to each registrant. We will send you the announcement that the recording is now available. It'll be on the website, the Maryland Nursing Workforce Center website, and the NSP2 websites. It's going to be a YouTube type thing, so you will go to YouTube to see it. It'll be a link, and it will be available to you to use. You can download it, but we can't. We just don't have the ability to send it to everyone's email box. So other people saying we only need the link, and that's what you'll get. You'll get the website link, and we'll notify you when. It takes a couple days for us to edit and get it posted up on the YouTube type link that we use. Okay.
Okay.
I think that's it. People are very appreciative.
Yeah,
very appreciative. Yeah.
I think you've crossed this finish line, one of many. 500 goes on and on. So that, and here's some references and resources. And I don't have the one there for Lassiter, and it might have been on there at the beginning, but if you search for that Lassiter rubric, it will come up for you.
Yeah, it's pretty well documented. Another question about the CEs. Once you complete the evaluation form and send it in, you will get the contact hours. It's free. You do not have to pay a fee. After it'll be 2 to 3 weeks for the Office of Con Ed to process everything, but you will get a confirmation and a certificate that you can download. And people are saying thank you, Dr. Billings. We appreciate what you've done.
And thank you, Becky, for helping, and Sonia for being in the background there and getting me.
Oh, absolutely. Always need all that backup support. A lot of thank yous. We really appreciate all those who came to here today, and questions. If you have questions along the way, let us know. We'll try to find an answer for you.